Good morning. Thank you all for coming out. Thank you for having me and allowing me to talk to you guys. So I'm a dermatologist here at Northwestern. I originally was a pharmacist and then went on to do further medical school and medical training because I have a big interest in helping to find better treatments for various skin diseases. The diseases that I see are within the autoimmune connective tissue spectrum, so specifically Scleroderma, and part of the Scleroderma team at Northwestern. And I kind of wanted to talk a little bit about some of the findings that you can see in the skin in Scleroderma and then some of the treatments that we do for that. So we'll kind of just get started. So we'll be talking a little bit about some off-label use of some medications, so just wanted to make you aware of that. So one of the things I've found in my time so far is that patients with Scleroderma are some of the smartest patients. You all know your disease very well educated, very well versed. As you may know that there are a couple types of Scleroderma that we sometimes break things up into, whether it's the limited type or diffuse type. And that can have an impact on how much skin tightening or how much fibrosis, as we call it, affects the skin. But that also has an effect on the internal organs and the insides as well. So this is kind of one way that we break up the Scleroderma that we see. Now in Scleroderma, there's a couple things happening. There's inflammation within the skin and the organs. There's thickening, and that can lead to thickening of your internal organs, your blood vessels, but also the skin as well. Okay. And we're going to talk about that today. So we'll talk about some of the signs that we see on the skin. Some of these may affect you or may affect a friend or family member. The first one is calcinosis. So patients can get these hard, firm, almost chalky-like rocks in their skin. Usually it's near the joints, on the fingers. It can be minimal, just on one finger. It can be on multiple fingers, as you see in this image down here. You can even see in some patients in some of their x-rays that they have a lot more calcium, and even in other bones in their body. And it can be hard to treat when it gets to that level. So we generally like to treat this early and treat the disease early when we do catch it, and we'll talk about that. Some people may have noticed that they have these red spots on their face or their hands. We call these telangiectasias. Some people get these from sun exposure over the years, but this is also a hallmark finding in Scleroderma. You can get it on the face commonly, the tongue, the hands. But there are other changes of the skin on the face. Some people can get this wrinkling near the mouth, what we call furrowing. And that's kind of a sign that the mouth might be tightening over the years. The nose can become a little tighter as well. And then some people may notice that the mouth also becomes tighter, and how wide they're able to open the mouth can decrease over time. And you can see there in that photo, they're actually measuring the mouth opening, and that's something we do at all of our visits, is we kind of keep track of that. And we'll talk about why and what are some things we can do if that's getting worse. But it's very important that we keep track of that because, we have patients who have told us that over the years they've had to slowly decrease the amount of food that they take with each bite, or even the amount of food they can eat on a daily basis, which can lead to weight loss. There are also some changes that can happen to the nails. Some people can get almost brittle nails or some nail changes, but also near the cuticle. If you've seen your dermatologist or rheumatologist, you might see that we're always looking at the cuticle. We're looking at the blood vessels there, okay? And in this first image on the top left, that's kind of normal, healthy cuticle and very fine, straight blood vessels. But what happens as the Scleroderma gets worse is those blood vessels get a little bigger. And we can even start to lose some of the blood vessels on our fingers. And we're looking at that. We're describing that. And that's because that can tell us, one, how the scleroderma is doing, but that also tells us if someone is prone to getting ulcers on their fingers. And that can be a very important thing, especially here in Chicago with the cold. And, getting ulcers on the fingers is a thing we really try to avoid. Okay. So if you're ever curious what we're actually looking at when we look at your cuticles, this is kind of what we're looking at. Now, going on to the fingers, the majority of patients with scleroderma may have Raynaud's. And that's when the fingers start to change color in the cold. They often turn white, like in that top left photo, and that's when the blood supply kind of gets closed off to the fingers. And then when it stays closed off, it starts to turn blue. And then it kind of turns red as the blood gushes back into the fingers. This can be very painful. This can be very problematic. We'll kind of talk about some things we do to manage it, but this is a very bothersome symptom, even in the summertime. A lot of places they blast the AC. So if you're in the grocery store, you're in the bank, your Raynaud's can become very active. And so we talk about things you can do to help prevent that. But this is something that a lot of patients experience. With the fingers, one of the things we really want to avoid are ulcers. So when the skin actually starts breaking down near the tips of the finger. And that can happen if the Raynaud's doesn't go away in an acute episode, if it stays blue, or even just on its own. Patients can get ulcers on the fingers. And that's something we really try to avoid, because if those don't heal, that can lead to bad things for the finger. Okay. So that's kind of one of the big things we really try to avoid. And I see patients who, if they have an ulcer on their finger, I'll see them twice a week. And I'll see them every week until it's starting to look better, because we do not want that going south. Now the hands, very common for people with scleroderma to have their hands be affected. You may have noticed that early on, when you were, maybe even before you were diagnosed with scleroderma, that your hands were kind of puffy. They were maybe more swollen. And we call that the early phase of scleroderma, when there's inflammation in the skin that's causing it to be swollen. And that can be a sign that the scleroderma is active, and then it might then turn into thickening. So if I would switch these two photos. The next phase would be when it starts to get tight, and you start to get what we call fibrosis, or tightening of the fingers. And that can lead to people not being able to open their hands and fingers fully. They can start to get contractures, or where their fingers, they can't really open it much. And so these are some of the stages of what happens to the hands as they progress, as if things are not treated, or just with time. Now, tightness also doesn't necessarily need to be on the hands. It can be on other parts of the skin. So whenever people come to see me or see their rheumatologist, you may see that we're kind of checking the tightness in a lot of different areas of your body. And there's a specific scoring system that we use on a scale of 0 to 3. And we actually grade every part of the body, not just the fingers. And we'll talk about what body areas, but there's 17 different areas. You can see there the chest, the thighs, the upper arms, and that can tell us over time. And that's one of the things about seeing a physician who's part of a scleroderma program is, we keep track of these measures, and we can kind of track it over time to see, are you developing more tightness over every appointment, over the years? So this is actually a very helpful tool for us. You can see patients can get tightening in other areas. So you can see how the abdomen or the belly in that top left photo looks kind of shiny. And same thing in the chest. That's starting to become tight. And it can affect the lower legs, the thighs. So these are all areas that we check to see if patients are starting to get tightening of their skin in all over their body. The skin is the largest organ, and so there's a lot of skin that we need to evaluate to make sure it's healthy. Some people may have even seen this. This is what we call a salt and pepper discoloration. And some people, they come to me or they come to us and they think it's vitiligo. Where vitiligo is a condition where people start to lose color of their skin. And, I could kind of see that. I could see that, they're losing color, it's starting to turn white. But this is actually not vitiligo. This is a sign of scleroderma. And we have to have a keen eye to differentiate vitiligo from scleroderma. Because if a patient has this, then we need to work them up, see if they have scleroderma, see how their lungs are doing, their heart is doing. So it's important also if you have this and you don't, as far as don't have other finding of scleroderma, we should make sure this is not scleroderma. Now we'll talk a little bit about some of the management that we do. Okay. Now, many of you may be on some of these treatments at some point or another. Mycophenolate is a very common medication we use in scleroderma. We use it for the skin. It helps reduce the tightening and inflammation in the skin. It's also helpful for the lungs as well to help decrease the fibrosis that's happening in the lungs. Methotrexate was a medication that historically has also been used for scleroderma, especially if patients might have joint pain or joint disease. Some of the newer medications that we've been using include what are called JAK inhibitors. You might have seen commercials for these on TV for eczema or psoriasis. This is a newer class of medications that we use for patients who, even after trying mycophenolate or methotrexate or some of the other medications at the bottom, if they're still having active worsening disease, we talk with patients about JAK inhibitors. Now, they're not necessarily benign medications. They are what we call immune suppressing medications, and there are side effects that we talk about. But we kind of have to have that discussion with patients about the benefits versus the risks. And so this is a newer class of medications that we've been using, especially for patients who have more tightening of their skin. There are studies that have shown that this class of medications can help kind of stop that progression. We'll talk about that ultraviolet A1. We'll talk about that in a second. But there are also some stronger medications like infusions of immunoglobulin or rituximab that we use, sometimes for the lungs as well. And there's a newer class also. So I wrote down there what's called IL-17 inhibitors. We use that actually for psoriasis. And there's been some data that has shown that actually that class of medications can be helpful at decreasing the thickening of the skin in scleroderma patients. So that's actually some of the research that I'm doing at Northwestern is we're looking to see if that psoriasis class of medications may actually be helpful, because it's actually a very safe medication without a lot of side effects. One of the things, and I think Dr. Richardson is going to talk about this later today, but just as my background as a pharmacist, one of the things that I talk to all my patients about are side effects of medications. Drug safety, patient safety, those are very important things that we need to make sure everyone knows about. What are the side effects of the medication you're taking? What do you need to be on the lookout for? And so we're always looking not just for better treatments, but safer treatments as well. Now, going back to that ultraviolet A1, I want to talk a little bit about this. This is something we have in our dermatology department. There are only a few academic centers in the country, and even worldwide, that have this. It's a special type of light. It's a special type of ultraviolet light, but just a very narrow window of it that we actually, for patients who have scleroderma, where their hands are tightening or their body is tightening, we have these devices. We've got this little guy here, and we've got also our standing unit as well. This guy kind of looks like one of our friends. And we actually shine that light at the areas of thickening. And what it does is it decreases the inflammation in the skin that's causing that fibrosis, that's causing that thickening. And one of the best parts about this is it's not a systemic medication, it's not a pill, it's not an injection. There's really no side effects long term. It doesn't increase the risk of skin cancer. It's a very great treatment. We have it at Northwestern. Some of the other academic centers, a few across the country, have. So we're very fortunate to be able to have this and offer to patients. These are some images of some patients who, from the left to the right, that was as far as they could close their hand on the left. And then after doing the treatment, we were able to decrease the thickening, the inflammation, and we're able to get more movement in their fingers or even other parts of their body, their chest, their mouth. So this is something that many of you may not have heard about. Like I said, it's only available at a few centers across the country. But I would definitely write this down, let your friends and colleagues know if this is something that might be beneficial for you or anyone you know in the community. Now we're going to talk about some of the things that I mentioned, some of the other skin signs, and how we can treat that, how in dermatology we often go about trying to help some of those skin issues. Now, oral tightening, patients who are getting tightening of their mouth, a couple of the things that we do. So number one, we need to make sure the scleroderma as a whole is doing okay. And whether that's with a medication like mycophenolate or something else, we need to make sure the disease is being treated. But there are also some local things we can do, okay? Now, these are some images from some research that has been done elsewhere. And obviously, they're picking the best photos, so this isn't going to be the case for everyone. But on the top right, that was a lady who was opening her mouth as wide as she could, and they treated her with Botox to try to loosen up the muscles around the mouth to increase the opening of the mouth. And we do that in our dermatology clinic for patients. I'd say some patients have not had great success, some patients have had. But what I've found the most is even increasing the opening by just the tiniest of millimeters, actually patients feel that. And they feel better about talking, about eating. So it doesn't need to be a great, robust increase in size. Even the tiniest of improvements can be very meaningful to people. The bottom left is what we call hyaluronidase. Sorry, bottom right. So if any of you have heard of filler, it's a cosmetic procedure that some people do where they put collagen into their face to kind of get extra plumpness in their cheeks or their face. Sometimes the cosmetic dermatologists who do that, let's say they put a little bit too much filler or the patients feel a little bit of that lumpiness or bumpiness, cosmetic dermatologists will inject what's called hyaluronidase to actually try to break down that collagen that was implanted into the skin. Now on the medical side, in our Scleroderma clinic, we actually take that property and we use it more for medical purposes. And we use it to try to decrease and loosen up some of the collagen that's tightening around the mouth. And that actually, I think, works better than the Botox. That lady on the bottom right was obviously that's a really good representation, but that was as big as she can smile on the left and then as big as she could smile on the right. So these are some things that we do in our dermatology clinic to help with oral tightening. We talked about telangiectasias, or those red spots. Now this is not obviously going to affect your scleroderma or your skin disease, but some people have come to us and asked about how we can treat it. And we do have, in our cosmetic dermatology side, we do have lasers that can help zap those blood vessels away. And it's actually relatively easy to do that. This is a lady who had scleroderma, and she was treated with that laser. We also tell all our patients to use sunscreen because the sun can also cause more of these red spots, these telangiectasias. Now, calcinosis, we talked about that. A lot of patients with scleroderma get those chalky, rock-hard growths. And that can be hard to treat. We want to treat it as early as we can before it gets very extensive. And there are some things that we do. We sometimes inject in our clinic a medication called STS, or sodium thiosulfate. And it can help break down and loosen that calcium to where it can then get absorbed by the body. Now, it's a little bit of a painful injection, I'll be honest. What we do in our clinic is we numb up the skin first to try to minimize that. But it's worked pretty well for patients who've had calcinosis on their fingertips, where those calcium stones are kind of interfering with their ability to type or do work, where it's just very painful. And so we can do things to break it down for them. That's very helpful. Now, there are other medications, for example, diltiazem. This is a heart medication. Sometimes you might even be on this for your lungs or your heart in scleroderma additionally. And this can also help decrease the amount of calcium that's getting deposited in your skin. Okay. Sometimes if patients have calcium stones on their arms or their legs, and you can kind of grab it and pick it up with your hands, those can actually sometimes even be cut out very easily by our plastic surgeons. Now, Raynaud's. Obviously, we've talked about Raynaud's. The one thing I tell my patients is non-pharmacologic measures are the best and most important, okay? So I tell everyone, wherever you go, even if it's the summertime, we talked about how the AC can be blasting. Have gloves, keep a pair of gloves in your bag. Always take it with you. You never know where you're going to be, where it's going to be very cold. And the last thing we want you to do is to start feeling a lot of that pain wherever you are, okay? There are other things we've recommended to patients or talked about with patients, so heated jackets. There are packs that if in case of it's really painful, really bad, you can break some of those packs that start to give off heat. We have patients who have that and carry that with them as well. But there are also medications that we use. So some of them are blood pressure medications like amlodipine, losartan, sildenafil, which is a stronger medication. But those kind of work to keep the blood vessels nice and open in the fingers, so where they're not closing off. We have a lot of our patients who are on that, and then they do work. Okay. Sometimes there are topical creams. Sometimes we'll even do Botox as well. But the important thing is, if it's not resolving, if you've got a finger that's purple and it's not getting better, it's staying purple, at that point, we're worried about the health of that digit, of that finger or toe. We don't want that to become an issue. We don't want to lose that toe or finger. We have a very low threshold for sending patients to the ER or to the hospital because there are things that can be done in the hospital that can open up those blood vessels. So for example, on the images here, this is a patient who was starting to get some ulcers on the toes. And they actually opened up the blood vessels in the leg to help save those toes. And you can see there, now the toes are not at risk of being lost. They also can give IV medications to open up the blood vessels because that's, like I said, one of the very important things is we have a very low threshold. We want to preserve that and not have any issues with fingers or toes. So like I said, I see patients back almost weekly, sometimes twice a week if I'm worried about the finger, just in case we do need to send them to the hospital. Okay. Now, leukoderma, we talked about this. As some people, initially it's thought as vitiligo. But one of the things we found is that this can actually get better with treatment. So patients who get started on a treatment for their scleroderma, their discoloration can actually get better. And there are a couple classes of medications, the JAK inhibitors like we talked about earlier. And we use that actually topically in vitiligo. So patients who have vitiligo, we use the same medication to try to get color back. And one of the things that we're looking at is, can we use those same vitiligo medications, but for this purpose, to try to get some color back? And this was a study that was done looking at a JAK inhibitor, tofacitinib, and showing that it did lead to color coming back for patients. And that can be a big improvement in their quality of life. Now, some of you that have scleroderma may know that scleroderma often doesn't come just by itself. Sometimes it likes to bring a friend, okay? And that can be myositis, that can be lupus, that can be rheumatoid arthritis or Sjogren's disease. And sometimes, when we see patients, there are subtle skin findings that can detect us or tell us that maybe you might also have something else, and we might also need to treat that, okay? So sometimes, patients get diagnosed as having scleroderma, and they're anchored with that diagnosis. The team is anchored with, you have scleroderma, and sometimes we need to stop and think and make sure that there's nothing else there in addition to the scleroderma. And that's kind of nice when we have our multidisciplinary colleagues and we see scleroderma, whether it's the skin doctors, the rheumatologists, the GI doctors, is we can kind of talk amongst ourselves and say, I actually think this patient has this and this, okay? And so we do have our scleroderma program at Northwestern. We have a great team. Some of you may see some of us in our clinics here at Northwestern. We are doing, a lot of research and a lot of clinical trials in this area, both for the lungs, but also for the skin as well, like I mentioned. So, why is the skin aspect so important? Well, number one, visibility, okay? It's very visible. So we have a lot of patients who are hesitant to even go to the grocery store, to even go out when their skin is very active. And that makes us kind of sad. We don't want patients to be burdened and have that low quality of life. We want to try to help get their quality of life better as well. Like I showed you, a lot of patients can have a variety of skin findings, okay? And that's kind of where we can come in as well in regards to the skin. But not just that, but the skin also is kind of like a window into how the body is doing. So like I said, we will look at your nails or your cuticles to tell us how the inside of your scleroderma is doing. We know that if you're getting more discoloration on your body, that's a sign that the scleroderma is more active. If you're getting digital ulcers or ulcers on the fingers, that the insides might also be kind of acting up as well. So we know that how the skin is doing is sometimes a reflection of how the insides are doing. And now, where do dermatologists play a role? Some people I've met have, been diagnosed and been treated for scleroderma for so long and have never seen a dermatologist. But that's one of the nice things about our team here, and we'll talk about that. But, like Stephanie was mentioning, some patients have gone years before being diagnosed with scleroderma. Their Raynaud's were chalked up to just, the cold. The red dots on the face were just chalked up to sun damage. But a keen eye can kind of tell us that you may actually have scleroderma. And the earlier we detect it, the better. We can protect the lungs, the kidneys, the joints. So the earlier it's detected, we know that the better outcomes we can have for patients. We talked about some of the treatments that we use for some of the skin conditions, whether it's oral medications, topical medications, and these are things that we're doing active research in, and we talk about at our national conferences in scleroderma to really try to get better treatments that are also safe in helping the skin. And most importantly is collaborative care, okay? So we're very plugged in as a team with our rheumatologists, our GI doctors, our lung doctors. We chat very often about, the patients that we share. And a lot of times we try to come up with a good plan together, okay? We think of the skin, we think of the lungs, we think of how the stomach is doing when we talk about treatments. And I think that's great when you can put multiple people together and have them to have these discussions and put their brains together. I think that collaborative care leads to better outcomes for patients. And I just wanted you to know that, because we often talk after the visit or at the end of the day. We'll send emails and messages to each other. And I want you to know that those are things that we're doing behind the scenes to really try to get the best possible treatments and care for you guys. And it's great that you're allowing us to do that. We appreciate that. I wanted to thank, obviously, some of the other members of the Scleroderma program who I work with relatively closely, but also the Scleroderma Foundation group and everyone for allowing us to come talk, myself specifically, but also on behalf of our dermatology department. I put my email address up there. If you or anyone you know have any questions about Scleroderma, being part of our team or coming to see our team, send me an email. I probably respond to emails way too soon than my fiance likes, but feel free to reach out. Yeah, exactly. So thank you all again for coming today and allowing me to talk to you guys.
Thank you so much, Dr. Vakharia. We're just going to open it up to questions, so don't be shy. We are going to pass around microphones because it's really hard when you can't hear the question, then you just hear a random answer. So we'll walk around. Arden, you got your hand up? Okay.
Thank you. Thank you very much for the presentation. Is there any possibility your UVA light or your phototherapy could help finger ulcers or contractures or anything else?
Yes. So specifically contractures. So the UVA1 light we do use for patients who have contractures and have stiffness of their fingers. And we know that that can help loosen up the fingers. Now, at some point, it depends a little bit on exactly how tight the hands are. But like I was talking about with the mouth, even the slightest of improvements in being able to open and close the fingers and hands, it can be very beneficial for patients. Some patients do really well, especially if we can treat it early. Now, in regards to the digital ulcers, the ulcers on the finger, yes, so we know that ulcers on the finger are a sign of inflammation in the skin and the blood vessels that are in the hands. And so the UVA1 light does also decrease not just the inflammation in the skin and the puffiness or the tightness of the fingers, but also can lead to a decreased number of ulcers that a patient would get in a given year, because it is calming down the inflammation.
Does that answer your question? Oh, follow-up.
Just one follow-up. Thank you. I saw the picture where the person was able to close the fingers better. Would they be able to open them further?
Yes, that's a great question. So so both. So we do, one of the signs that we often do is what we call the prayer sign in our clinic, and we check every visit how wide are they able to open their fingers? Are they able to start touching their fingers together? And with UVA1 treatment, or even the other treatments, we can hopefully see that they're able to start getting closer and closer to more of a prayer sign of hands together.
Thank you so much for being here and making your content very accessible so that it can be understood by
Thank
people, like me. Everything you talked about in your practice is all about understanding what the patient is experiencing by looking at them. So it's all about the eyes. So how do you understand where a patient is when their skin color is dark? So for those who have very dark skin, considering, again, everything you are trying to understand and treat is all about the eyes.
That's a great question. So I would say that a lot of things are by the eyes, but a lot of things also are tactile. So, we are feeling the tightness of the hands. We'll pinch every area on the body and we grade it on a scale of 0 to 3. So irrespective of color, we're able to see just how much thickness and tightness there is. That being said, also, some of these skin findings can be more subtle depending on the skin type, okay? So patients who are skin of color, those red, those spots that we talked about can be a lot more subtle. However, some things might be more visible, like the discoloration might be more visible. I think in general, that's kind of where a keen dermatologist and rheumatologist and team that focuses on scleroderma, that has had the experience of seeing those skin findings in a diverse group of patients, can be very helpful. Instead of, not being able to see those red spots or not being able to see the little calcium stones that are on the body. Those are things that it's a combination of seeing and feeling. But I agree, it does come with time, it does come with practice about being able to find some of those more subtle things depending on skin type. So that's a great question.
Snuck up on me. Just kind of like three questions, but they're related. When you talked about the UVA1 therapy, how many sessions does that typically involve before you see a benefit? You did mention it's non-cancerous, but anytime you hear ultraviolet, you're thinking that. So is it because it's like a specific wavelength that you're dealing with that is known to be non-cancerous? And then this is the other question. The IL-17 versus JAK inhibitors, both of those that you mentioned were treating psoriasis, but it seemed like the IL-17s did not have as much side effect. And I was just kind of curious what their method is of how they work in scleroderma that you might see one versus the other.
It's a great question. So the first two, one, we usually do about 30 sessions, give or take, in a given year. So usually by about, and if you're doing it once or twice a week, usually by 2 months in, we should, 6 to 8 weeks, we should start seeing if there's a little bit of benefit. Now, it may not be the maximum benefit you're going to get at the end of, because we know that at the end of the 30 sessions or so in a given year, that's when you would see the most. But we should, by 6 to 8 weeks, start seeing if there is some benefit. And you're exactly correct. It's a narrow wavelength of light that we're using for this, so it's not the whole spectrum of ultraviolet light that can be carcinogenic or cancerous. Now, in regards to the JAK inhibitors and the IL-17s, so the takeaway, to simply put it, JAK inhibitors are very broad immunosuppressants. So they suppress a lot of things in the immune system and a lot of inflammation. So that's why they currently work and we use it, but that's the one where we do need to have a discussion about risks and benefits because of that strong immunosuppression. IL-17 inhibitors target just one specific thing in the skin. Now that thing is very active in psoriasis, and there's some data that shows that that's active in scleroderma. So in terms of what would have the greater efficacy, probably the JAK inhibitors, because it's just broadly suppressing inflammation. But, that comes with a discussion about side effects.
Yeah, and just a follow-up on that. The IL-17, what's the path for approval, or is that used off-label?
It's a great question. It's used off-label right now. I would say probably not anytime soon would we be able to get approval for scleroderma. But it's something that we, in our dermatology departments, have access to with samples. There are ways to still get it approved off-label. So for example, when we have patients come to us, if we were to do this, we would use a couple of our physician samples, see if there's benefit, and if there is benefit, then we would petition the insurance company to cover it, and we would say that, look, this has worked also for this other condition. Here's the data that shows it. Here's why we'd like it to be covered. I think they're...
I have a couple simple questions.
Sure.
These looks like whiteheads on my face.
Mhm.
Is that the scleroderma?
No, I don't, probably not.
Okay.
Yep.
Because I do have the little calcium. My next thing is hand paraffin treatments. Am I wasting my time, or is that...
What was that?
You put your hand in paraffin, like paraffin?
Oh,
paraffin.
I got you. Oh, paraffin. Okay. I wouldn't want to say wasting your time, but I think there might be other measures to help that might be more effective.
And my last question is, I have Raynaud's, and I have tingling in my fingers, and I'm taking hydrochloroquine right now. Is there something better I could be doing for that?
For tingling, there are medications that we use for what we call neuropathy and other nerve-type symptoms, other medications in other classes that could potentially have more effect. Yeah.
Um,
Oh,
can-
go ahead.
You talked about the calcium channel blockers for the calcinosis.
Mm-hmm.
Like I take nifedipine for my Raynaud's. Will that also help with the calcinosis?
It's a great question. So there's two types of calcium channel blockers. There's dihydro and non-dihydro. The one that you're on is actually more like nifedipine, like this medication, which is not what we use normally. That's the other type of calcium channel blocker that we use more for Raynaud's. Doesn't help as much with calcium deposition. The other type of calcium channel blockers, like diltiazem or verapamil, those are the ones that we sometimes use for calcium. So a little different.
And they wouldn't help with the Raynaud's as much?
Correct.
Okay.
Correct.
I'm from the Twin Cities. Hi.
Hello.
And I'm pretty new to the scleroderma world. And this is the first time that I've heard of a skin doctor who has expertise in scleroderma. So I'm wondering how common your role is. How many colleagues of similar knowledge do you have around the U.S.?
That's a great question. You're right. One scleroderma is not within the realm of conditions, not the most common, but obviously a lot of people have it. And there are specialists within rheumatology, pulmonary, GI, and dermatology who focus on these conditions. So at Northwestern, I'm one of them. I would say primarily you would find them at academic centers. So for example, in Minnesota would be Mayo Clinic, potentially University of Minnesota. We have some colleagues at Penn, in Boston, and Texas, mainly at the larger academic sites, is where you not just would find dermatologists who are treating scleroderma, but the multidisciplinary teams and discussions. Now, there are dermatologists in private practice who also help manage scleroderma, but they may not be as in close connection with the other specialties. So I would say in general, to find a dermatologist with that expertise in the autoimmune diseases would be at an academic center. Yep. But thank you for coming from Minnesota.
I have a question to your left. I noticed that Botox was mentioned multiple times. I may be wrong, but I always thought Botox was used for like more tightening the skin. I was wondering how does it have the opposite effect?
It's a great question. Yeah. So we use Botox the cosmetic dermatologists use Botox to paralyze the muscles, let's say in the forehead. So you can't scowl, you can't raise your forehead. Now some people, I personally like my line, so that's a different use. We're paralyzing the muscles there, so you can't move it, and so it does stay kind of like tight, and it looks like someone, has like a frozen forehead, as they say in the dermatology world. What we do is we target some of the muscles around the mouth. So we have muscles that open the mouth, but we also have muscles that close the mouth. Okay, and we try to target very mildly. We try to target the muscles that close the mouth, not fully paralyze them, but make it a little bit harder to where you're getting a little bit less closing of the mouth and it's opening a little bit. So we're kind of like, instead of trying to open the mouth by Botox, we're instead trying to prevent too much closing of the mouth. It's a little reverse there. Yep.
Hi, I have two questions. The first is when you talked about hospitalization for opening up the arteries for digital ulcers, is that a lasting effect where the arteries open, or is that just temporarily while you're doing that? And what medications do you use?
Yeah, that's a great question. I would say it depends on what's being done to tighten or to open up. If it's just the IV medications, that is more of a temporary thing to allow the digit to heal and get really good blood flow. And then you would probably be started on a stronger medication outpatient to help maintain that effect. If it's something surgical where they're surgically opening up the blood vessel, then that would be more long-term.
The other question is, I noticed when you were on your slide about overlapping conditions, little comment there, it says there's an increased mortality in the overlap of Sjogren's and scleroderma. Why is that?
Yeah, that's a great question. So, one, because patients can get a blood vessels being affected in scleroderma and Sjogren's disease. So there are some complications that can arise just by having not just the skin, not just the lungs, but blood vessels being affected as well.
I wanted to ask about you had Botox up there as a treatment for Raynaud's.
Mm-hmm.
Is that to help avoid the finger ulcers?
Yes, the Raynaud's and the ulcers, and the goal of that, and I don't do that as commonly. I'd say that's something that we do more if the other treatments aren't working. The goal of that is to also try to help keep the blood vessels open a little bit. There are some receptors on the blood vessels, and we try to help keep them open a little bit with the Botox.
Okay, and is that, we've just heard different opinions from different doctors about the effectiveness of that.
I would say in my experience, it's not as effective as the other options, but it's something that can be tried because it's not a long-lasting medication. The side effects are generally minimal with Botox. So for patients where it is beneficial and they have had benefit, it's something we can keep doing. But from my experience, I wouldn't say it's the best treatment. It's not something we jump to right off the bat.
I had a question over here. I had a couple of questions. Since the stiffening of the skin I'm assuming it does affect the muscles as well, or like from scleroderma, and if that, for those who have like osteoporosis and like scoliosis or kyphosis, do you recommend from your patients to see a spinal surgeon or anybody that can release, the relaxation, kind of like what Botox does?
Yeah, that's a great question. I guess I would say, from my understanding, scleroderma usually affects more of the layers of the skin above the muscles as opposed to affecting the muscles specifically. I don't want to answer too much about the latter question. That's a little bit outside of, I'd say, my specialty. That might be a better question for Dr. Richardson or the rheumatologist when they come.
Okay,
Yeah.
Thank you.
Yeah. I think there was.
All right, maybe one more. I think Jackie, you had a question, and then maybe one more. Are you able to stick around?
Absolutely. I'll be here in the break as well before lunch, so.
Hi. I have two questions. One is, with the Botox, is there a difference between when a neurologist does Botox and when what's the difference? And would it be safe for somebody who has celiac like me?
So yes, it would be safe in celiac disease. The medication's the same between a neurologist and a dermatologist. I'd say it's more so where we do it. So a neurologist commonly does Botox for migraines or other areas. I would say someone doing it who's done or had the experience doing it on the fingers or around the mouth is maybe someone you'd want to see, but in terms of the actual medication and process, it's the same.
Okay, because my neurologist suggested the Botox, and I didn't know if they do different points.
Yes, we do at different points of injection.
Okay.
Yep.
And then the second one, the diltiazem, how does it work with patients with scleroderma?
So we use that for the skin purpose. It basically helps by decreasing the amount of calcium, in theory, that can deposit, that's in the blood and that can deposit into the skin. So ideally, it can lead to less calcium deposition over time by inhibiting the calcium depositing.
But if you don't have calcium deposits,
Okay, then from a skin perspective, we probably wouldn't use it.
Okay.
Now, for the lungs or the heart, sometimes it might be used. That I would defer to like the pulmonologist.
Okay, we're going to take one more question and try to stay on schedule here, and then we'll move on to the next presentation. But thank you. You are going to be around during the break later? Okay, great. So if you have any follow-up questions that didn't get answered, hopefully you can catch them during the break.
Thank you. Quick question on the slide that's on the screen. What does the numbering system mean there?
Oh, that's a great question. I would say that, so this was a study that was done looking at proportions of patients who have had which autoimmune conditions overlapping. So we commonly see rheumatoid arthritis as one of the more common diseases that comes with scleroderma. So that's like a gradient of which conditions and what percentage-wise would be associated with, let's say, 500 random patients with scleroderma. How many might have RA or Sjogren's or lupus? Yeah. All right, well, thank you, everyone. I'll stick around and feel free to email me as well if you need, okay?